If your patient is being treated with dialysis, they can be on hemodialysis or peritoneal dialysis. With hemodialysis, we will use access to their vascular system, and for peritoneal dialysis, we will instill the dialysis solution into their peritoneal space. The basics of dialysis is that the dialysis machine acts as the glomerulus for your patient. So you need to think about this as the kidney being outside of the patient. The machine is doing all of the work that the kidney would normally do. So what does the machine do? It filters, regulates, and removes fluid, waste, and electrolytes, just like the kidneys would. We start this at CKD stage 5 when the GFR is less than 15. And this all happens with a semi-permeable membrane. Typically, patients will have 3 sessions of dialysis per week, and each session will last 4 hours. So why is a large bore needle used to access the patient's vessels? It's because of the rapid, turbulent blood flow. You need something that can handle that. And then the types of access we use are the Quinton, the AV fistula, or the AV graft, and we have pictures of that on the next slide. If your patient has a Quinton catheter, that is going to be a temporary catheter placed in the internal jugular with the tip sitting in the right atria. You'll have a couple different ports, as you can see on this slide. There's a blue port and a red port that's used for dialysis. And then there's a smaller port in the middle that can be used as an IV. Only the dialysis certified nurses will use the blue and the red ports. However, the nurse can use the smaller middle section that acts as a normal IV to give IV medications. Your patient more permanently can have an AV fistula or an AV graft. So these both work in the same way. If your patient has an AV fistula, it's going to mature in 3 months. It's going to be in the patient's arm. And because it's in your patient's arm, you need to make sure they have a limb alert bracelet. And then you'll assess for a thrill and a bruit. If they have an AV graft, it's going to mature in 2 to 4 weeks. It will also be in their arm. So because it's in their arm, they'll still need a limb alert, and you will assess for a thrill and a bruit at the site. But the difference is that this uses synthetic material. So we like to use these in patients with peripheral vascular disease. So if we're having trouble with their arteries and their veins, this may be a good option. The fistula uses your patient's own arteries and veins to create the access for dialysis. So when you're doing your assessments and you need to assess for a thrill and a bruit, you're going to palpate for a thrill and you're going to auscultate for a bruit. And you should be able to feel and hear that rapid, turbulent blood flow. Continuous renal replacement therapy is a form of hemodialysis that is used to treat an acute kidney injury, but is done in the ICU setting. It's much slower, and only about 80 milliliters of blood is pulled out of the patient into the dialysis machine at a time. And this is because these patients are typically not as hemodynamically stable as a healthier patient who can tolerate dialysis in the clinic. So this can be done up to 40 days, and because it's temporary, they can use a Quinton catheter. Peritoneal dialysis, the patient will have a catheter surgically placed in their peritoneal cavity, and the peritoneal space is going to act as a semi-permeable membrane to filter and regulate all of the things that the kidneys would normally do. So with this, there's going to be a bag of dialysis solution, as you can see on this slide, that's going to be instilled into that catheter, into the patient's peritoneal space. There's going to be a prescribed dwell time for that solution. So that solution will sit in the peritoneal space as long as the healthcare provider says it should, And that's when all of the filtration and the regulation of everything, the fluid and electrolyte balances, all of those things happen. After the dwell time is up, you will reconnect a drainage bag to that catheter and drain out all of that fluid that has been dwelling in the peritoneal cavity. So there's a couple different ways to do this. It can happen automatically while the patient is sleeping, where they connect at night before they go to bed and they disconnect in the morning. They usually do this up to 6 nights a week. Or they can do a continuous ambulatory peritoneal dialysis where they cycle through this every 4 hours. So it's a continuous cycle of instilling the dialysis solution and then hooking up to the drainage bag to drain everything out. So what your patient ends up doing is going to be dependent on the patient and their condition and what the healthcare provider decides. Looking at complications, with hemodialysis, we really worry about hypotension. We worry about drops in blood pressure because we're filtering out fluid. So we're pulling fluid out of the vascular space. And anytime we pull fluid out of the vascular space, we're lowering the pressure in those vessels, so we're lowering the blood pressure. We also worry about hypotension during the dialysis treatment because your patient always has some blood that's going to be out of the body and in the dialysis machine. We worry about muscle cramps because of the drastic changes in electrolytes. And then we worry about blood loss from the access site itself. For peritoneal dialysis, we worry about infection, which we call peritonitis. And the reason we have such a high risk of infection with this is because peritoneal dialysis is done at home. It's not done in the clinic, and we can't control the patient's environment. We also worry about hernias, back pain, and shortness of breath. And all 3 of those things are related to an increase in fluid pressure from the dialysis solution. So all of that pressure can cause a hernia, back pain, or even shortness of breath if their diaphragm can't expand as easily. We also worry about bleeding from the access site, and we worry about protein loss. And that's just because of the way the dialysis solution acts. So remember, normally we want to restrict protein with kidney patients. However, this is going to be your exception. So we are not going to restrict protein in peritoneal dialysis patients. So now that we've talked about complications, why might the healthcare provider order to hold morning antihypertensive medications if a patient is scheduled for dialysis? Well, that is because we are worried about hypotension. We're worried about that will drop their blood pressure too low with the medication, and then they won't be able to go to their dialysis treatment at all because their body won't be able to handle losing blood into the dialysis machine. Or we worry about them going to dialysis, they pull some fluid off, and the combination of pulling the fluid and the blood pressure med drops their blood pressure too low. With these labs, you can see that the patient's kidney functions and electrolytes fluctuate based on their dialysis schedule. And this is typical of dialysis patients. If they go to dialysis one day, their morning labs the next day typically look a little bit better. And then if they don't go to dialysis, when we draw blood work the next morning, their labs typically get a little bit worse. When we look at these labs, we can see that this patient has a low red blood cell level, a low hemoglobin level, and a low hematocrit level. So we are thinking that this patient may be anemic and may be blood. Whenever you're looking at your hemoglobin and your hematocrit levels, your worry numbers for a blood transfusion are 7 and 25. So anytime we see that our H&H is 7 and 25 or lower than 7 and 25, we should be thinking that this patient may need a blood transfusion. On this slide, we see that the patient from the last slide got 1 unit of packed red blood cells. So looking at these labs, did it help her? Yes, we can see that her red blood cells, her hemoglobin, and her hematocrit have all gone up. And her hemoglobin and hematocrit have gotten out of that worry range of 7 and 25. Another way to treat chronic kidney disease stage 5 or end-stage renal disease is for your patient to get a renal transplant. Of course, before your patient gets an organ transplant, we're going to look at the risk versus benefits, and we're going to consider antigen matching to see if their body is likely to even accept the organ. The big benefits of this is that it can greatly improve the quality of life of the patient, and it can reverse a lot of those lifestyle and dietary restrictions that we've talked about with chronic kidney disease. Donated kidneys can come from either a live donor or a deceased donor. A live donor will need to undergo medical evaluation and counseling. They need to know that the surgery may be laparoscopic or open. It just depends on a lot of things. And that they will be in the ICU for 24 hours post-op. The live donor must also be physically healthy, mentally ready, and have no risk for developing kidney disease themselves. For a deceased donor, after the patient passes away, the patient needs to be on the ventilator to support the organs. The kidneys need to be perfused. So kidney donations would come from patients who were brain dead but previously healthy. In the transplant pre-op stage, informed consent needs to be gained from the patient. The nurse's role in informed consent is to witness the signature of the patient. The patient should also be educated that the new kidney might not function immediately. So after surgery, the patient still may need a few dialysis treatments while the new kidney is getting acclimated to their body. It doesn't mean that the kidney's not working. It just means that the kidney needs some time to get adjusted. In the post-op phase, I&O should be monitored very closely. Medication-wise, your patient will be put on immunosuppressant therapy, so probably a combination of immunosuppressant drugs and steroids to weaken the immune system. The reason we want to weaken the immune system is so that the immune system does not fight off the new transplanted kidney. There is a fine balance with this. We want to weaken the immune system enough so that it doesn't fight off the new kidney, but we still want to leave them with some immune system to be able to fight off infections. They will be on these meds for the rest of their life. So what complications can we expect to occur with steroid use? With steroid use, we worry about brittle bones, so weak, brittle bones. We worry about increased blood sugars, and we worry about suppressed immune systems. When your patient is on long-term steroids, make sure you are closely monitoring their white blood cell counts because they are going to be at a high risk for infection. So of their bones, blood sugar, and immune system, we need to make sure we are prioritizing that immune system and keeping them safe from infections. Transplant complications. We worry about infection, we worry about rejecting the organ, and we worry about acute tubular necrosis, which is kidney damage from prolonged cold time. And the cold time is the time the organ spent outside of a body. So the time it takes to harvest the kidney from the donor patient to transplant into the recipient patient.